In our first hour, we'll have two wonderful speakers. The first is Karol Bomsztyk. Karol came here in 1983. He's a professor of medicine and an adjunct professor of pharmacology. He got his MD from the University of Rochester, and his area of study is gene expression using genetic, biochemical, and computational strategies to understand diseases with the hallmark of abnormal cell proliferation. What does that mean? Well, it actually means he's really, really smart. He's also a fantastic historian, and one of the things he's going to do tonight is talk about heart disease. He's received a number of awards. The American Heart Association gave him the Established Investigator Award, and he's got an NIH Merit Award, which is the federal funding agency. The other speaker that I'll introduce is Steve Goldberg, associate professor in cardiology and interventional cardiologist. He came to the University of Washington in 2000. He did his MD at the University of Kansas, his residency at Cedars-Sinai, and then did a cardiology fellowship at the University of California, and then also in Milan, Italy. He's recognized across the institution as the person you want to go to if you need an intervention for your heart. He's got very gifted hands. His area of expertise, coronary stenting, balloon valvuloplasty, intravascular ultrasound, intracardiac ultrasound, and percutaneous device closures for defects in the wall of the heart. And so with that, I'm very pleased to introduce Karol.
Thank you very much, Norman, for this very nice introduction. So today what I'd like to talk to you about is one of the most common diseases in the Western world, and that's hypertension. In the last 100 years, the life expectancy nearly doubled, and the spectrum of the healthcare burden switched from infectious disease to cardiovascular disease. You might find that surprising, but today the major healthcare burden really relates to cardiovascular, cerebrovascular, and kidney disease. And in fact, cancer is second to those. So this is a major healthcare problem. One of the contributing factors to cardiovascular disease is hypertension. About 60 million hypertensive individuals, those are people with high blood pressure in this country alone. And hypertension contributes to heart disease, strokes, and kidney disease. And hypertension incidence increases as we get older. Blood pressure, when it's elevated, damages multiple organs, such as the brain, the eye, the blood vessels, heart, and the kidney. Among us here in this audience, about 50% of us will die of disease related to the heart, diabetes, kidney, and only about 30% from cancer. So the cardiovascular disease is obviously a very major problem. What I'd like to do during my short presentation is to take you through the advances that have been made in the area of cardiovascular disease as well as hypertension, and how the advances have been shaped by historical events, socio-economical changes, scientific discoveries, and a disease of a very extraordinary man that changed how we do research today. Cardiovascular disease is actually ancient. They have done autopsies on Egyptian mummies, and that was nearly 5,000 years ago, and found that in those mummies, when they look at the arteries, that there was evidence of atherosclerosis. So this is a disease that has been around for a long time. Also in Chinese writing, there is a mention that individuals that have a pulse that is very difficult to occlude are more likely to develop strokes. And that would be related to to hypertension. It turns out that in regards to blood pressure, the first descriptions have been made also about 5,000 years ago and are attributed to this emperor Huang Ti, who had written this book that addressed many issues, including health issues. And he postulated that there was circulation of the blood and that the heart was the key organ that pumped the blood. There was also a Hindu writing about 600 BC, where in the Hindus, they took cadavers and showed that you can circulate blood through the cadavers, again indicating that there is blood circulation. And then came the Greeks. And Hippocrates is considered the father of modern medicine. And when we graduate medical school, we take the Hippocratic Oath. And so he taught us that the veins carry air. And he had many followers. One of his famous follower was Galen. And he had this idea that actually blood was synthesized or produced in the liver and just was sent to the body and was just sitting there. So the notion of blood circulation was put on the side. And the Greeks made a tremendous contribution to astronomy, physics, philosophy, mathematics, and medicine. So they gained a reputation as being extremely smart. So for 1,500 years, nobody would dare to challenge the Greek dogma. Well, the Greeks have to be credited with the fact that they were the first ones to actually ask themselves, is there a base for disease other than something divine occurring? And they came up with this interesting idea that in health you have a balance between four major humors: blood, phlegm, yellow bile, and black bile. And when an individual was sick, it was the job of the physician to restore the harmony of these fluids. So for hundreds of years, people were always searching for remedies that would either make you urinate. Bloodletting was also common, as well as medicines that made you vomit. And this was all meant to restore that harmony. And this kind of teaching got into religious teaching, and that dogma persisted for a very long time. Things started to change a lot with the discovery of Gutenberg of the printing press. Because what that allowed to do is to print books in a mass scale so that many more individuals could have access to knowledge. Because prior to that, the group of individuals that had access to writing and reading were the monks, and they, of course, represented the church, so they would not challenge the religious dogma. But with the Gutenberg press, all of a sudden, information started disseminating. So the more people that you have exposed to knowledge, you will have as a product more ideas coming through. And that was really a springboard for explosion of scientific knowledge. And Copernicus was really led the way. The astronomers, they had a laboratory up in the sky. This was something that they could easily probe. So that's sort of the modern science began. And he, of course, postulated that it is the Earth spinning around the sun and not the other way around. And that teaching was then taken up by Galileo, who is considered the father of modern science. What that means that they carried an experiment, they had hypotheses and then tested that. And this was, of course, against the church teaching. So Galileo was lucky because he actually knew the Pope, so his neck was spared. Interestingly enough, he was another Polishman, John Paul II, that 400 years after Galileo actually exonerated him. So it took that long to break this dogma. Now, what Galileo also illustrates is another important point. He couldn't do this all by himself. He had a sponsor, and these were the Medici family. They were sort of gave the rise to the modern research sponsorship and set the example for centuries to come. Now, what about medicine and blood pressure? Dr. William Harvey is credited with the discovery of blood circulation. And this was considered such an important discovery that he was knighted. And he did a very simple experiment and postulated that there is blood circulation, that veins and arteries are connected by capillaries. But the question that I asked myself, is that really his original idea? At the time, Britain became a seagoing power, and I wonder whether Mr. Harvey got a hold of Chinese books and read about blood circulation that was postulated centuries before and basically confirmed what the Chinese had postulated. And this is an important point that I will make throughout my short presentation, that communication or bridging ideas across countries, continents, and scientists is a very critical element for scientific discovery. Interesting, it took another 100 years for the first blood pressure measurement to be taken, and that was by Dr. Stephen Hales. What he did is took a horse and stuck a brass tubing into the carotid artery, connected gooseneck to that brass tubing, and then connected a glass tube to that. And to his amazement, he found that the blood went up 9 feet. This was such an amazement that he got knighted. And this is important because the British Crown set an example for rewarding scientific discovery. He became very famous. Unfortunately, the horse died. Then it took yet another 100 years to do a first blood pressure measurement in a man, and this was this Ludwig chymograph. So as you can see, in the beginning, things were going rather slowly, but nonetheless, these discoveries, although from our point of view they seem sort of rather trivial, they were very monumental and they were highly rewarded. Just to put things in perspective, these days the only way you can get knighted is either if you're Bill Gates or Mick Jagger. The way that we measure blood pressure today is the systolic and diastolic blood pressure. And that was first described just merely 100 years ago, in 1905, about the same time that Model T came out. And this was pioneered by a Russian physician who basically used a stethoscope that was invented by a French physician, Laennec, during French Revolution. And then there was an Italian physician, Riva Rocchi, that discovered the sphygmomanometer that is driven by air that we put on our arm to measure blood pressure. And he combined those two discoveries and taught us how to measure blood pressure, and that's how we do it today. And again, the slide very nicely illustrates that all these achievements were possible because you had people from different countries getting together and learning from each other and coming out with these major advances. And that is, of course, true today, very much so. It was not until the mid-19th century that physician extraordinary to the Queen, Sir Richard Bright, that actually first described kidney disease. And when I was in medical school 30 or 35 years ago, actually kidney disease was synonymous with Bright's disease. So he first described kidney disease. But it was not until the actually late 19th century that a British physician, Mohammed, first started measuring blood pressure regularly in his patients, and he made the connection between high blood pressure, heart disease, and kidney disease. But it was not until really the 1950s that we really began to appreciate the ravages of hypertension in regards to the different organs that high blood pressure damages. 20th century brought some major discoveries, and there were two discoveries that totally changed the landscape of our healthcare burden. And when I ask that question, many people guess that one of the discoveries, and that's the discovery of penicillin by Dr. Fleming. And this was total serendipity. He discovered that by an accident. He discovered it in 1928, but it was not used until 1943. Because that was during the war where there were a lot of wounds, a lot of infections. So that historical event served as an impetus to make penicillin available to the soldiers. And that had really started eliminating infectious disease as the major cause of death in the Western world. I wonder if anybody in this audience would guess what is considered another perhaps the most important discovery in regards to changes in our healthcare burden. Actually, it's considered perhaps the most important discovery of the 20th century, and that is how to synthesize ammonia from air. Because what that did is gave rise to artificial fertilizers, and the food production increased tremendously. So this is the Haber-Bosch process. So what that happened, not only you produced a lot of food from the field, but that food can then be used to feed to livestock and produce meat. So all that has contributed to abundance of food, and changes in our diet has contributed to cardiovascular disease and diabetes, obesity, etc. But also, the introduction of artificial fertilizers had another important implication in that people were preoccupied. Most of people back those days were working on the farm, but with increased food production, that freed up hands, and people could go to the cities and get educated, exposed to knowledge, and then had an opportunity to contribute to scientific discoveries. So, and likewise in other sectors of our economy. So this indeed is considered very important. There was one very famous patient that put the entity of hypertension on the map, and that was President Roosevelt. President Roosevelt was an extraordinary man, and he gave us Social Security, Grand Coulee Dam, but at age 55, he developed hypertension, high blood pressure. And this graph shows you how much his blood pressure went up in the next 7 years. He developed heart disease and probably had kidney disease because he had some protein in the urine. The guy was absolutely amazing. Through all that, his blood pressure was through the roof. He managed to actually run 4 times, and the 4th time he beat Governor Dewey. He got like 432 blue votes, and poor Dewey got just 99. And he did that while being pretty sick. He also decided the fate of Europe with Stalin in Yalta. Stalin obviously took advantage because I don't think Mr. Roosevelt felt all that good. April 12, 1945, while being in Warm Spring, Georgia, Roosevelt complained of very severe headache, and with no treatment available in the United States, he died. And it was just, to me, when I learned it, it's absolutely remarkable, the most powerful nation in the world, and Mr. Roosevelt was left dying. When you look what Mr. Roosevelt represents to scientific or medical advancement, it's rather interesting. The panel on the right shows he had an incredibly ceremonial funeral, but yet his death certificate was very much ordinary, unceremonial, and that's on the right. The only difference between this death certificate and anybody else's death certificate that on the occupation said President of the United States of America. So he was an incredible individual, but he had a very ordinary disease. And this was a wake-up call in this country. I mean, how could we let this fellow die? He was a president. We didn't do anything for him. And so that actually was one of the springboards for beginning to have sponsored research. That's when NIH, in part due to, as a credit to Mr. Roosevelt, started giving extramural grants to people like myself working at the universities. So this was a very important development. So he made so many contributions, but unbeknownst to him, by his death, what he represented, the disease that he had, he made yet another contribution. So what was the treatment available during the time when Mr. Roosevelt died? And this was this procedure that was described 80 years ago by Mayo Clinic surgeons. It's called sympathectomy. It was published in 1925 in Journal of American Medical Association, a very, very famous journal. And they did this really barbaric procedure. They went into this young man. They whip out what we call a sympathetic ganglia, and while they were there, they also removed the adrenal. Needless to say, this procedure didn't help. But the interesting thing, they went on to do this for another 30 years. So the last procedure, I believe, was done in 1955, during my lifetime. Now, you might think 1955 was a long time ago. That's a little over 50 years ago. But if you look at another calendar, that is of rock and roll calendar, in 1955, when America discovered Elvis, we certainly don't think of Elvis as being all that old. The first medical therapy for hypertension was reserpine. And that was introduced about 50 years ago. And what reserpine represents is what a gift from Mother Nature. In fact, it was first discovered by Hindus who used that for literally centuries as a remedy for multiple diseases. In 1930, Calcutta doctors reported that extracts from that plant, and the active ingredient was reserpine, was effective in lowering blood pressure. And then in 1940s, millions of people in India were treated successfully with this extract from that plant, which is reserpine, while our president, Mr. Roosevelt, FDR, was left dying because who would, back those days, pay attention what the people in Asia were doing as far as treatment. Reserpine actually is a very effective antihypertensive medication, but it has dreaded side effects. So it's very rarely used today. Another group of medications are diuretics or water pills. And diuretics have been around for a long, long time. As I mentioned to you, physicians were preoccupied always to try to find remedies that make you urinate because that would restore their harmony. So in fact, there was this alchemist, Paracelsus, who became very famous because he discovered that the compounds that have mercury make you urinate. And that, of course, was thought to be a good remedy. But diuretics became very useful in the treatment of high blood pressure because it decreases the volume of blood, in part that contributes to the high blood pressure. So in the last 50 years ago, some very good diuretics or water pills were introduced, such as hydrochlorothiazide. And in 1962, furosemide was introduced. And that is just a very potent and very safe drug. And in fact, would serve as a paradigm for what a good drug should be, and has been very successfully used since those days. So again, 1962, when I think of Lasix, I think like ancient history. But then when I look at my rock and roll calendar, in 1962, the Beatles put out Love Me Do. So it really wasn't all that long ago, and every so often I listen to KZOK, Breakfast with the Beatles, and I enjoy it and feel very young. The major system that regulates blood pressure is the renin-angiotensin system. And it took really 100 years to really define the entire system. And there is one hormone, angiotensin II, which is the key player in regulating blood pressure. And through millions of years of evolution, angiotensin II and the whole system served very well for us to maintain blood pressure and ensure that our organs are perfused. But today, this activated renin-angiotensin system is a major contributor to cardiovascular and renal disease. Again, a reflection of the imbalance what Mother Nature gave us and how we live. So as a result of that, there are a number of drugs that have been introduced to target this activated renin-angiotensin system. And one of the group of the drugs is the angiotensin-converting enzyme inhibitor, or ACE. And this is considered the most important discovery in internal medicine in the last 25 to 30 years. And this also was a gift from Mother Nature. There was a Brazilian physiologist that found that in snake venom, when you inject it to rodents, it lowers blood pressure. So he got together with a British scientist. They isolate the active compound, and then pharmaceutical industry synthesize a compound that you take by mouth, and that's captopril, that controls blood pressure. But these drugs are enormously effective not only in lowering blood pressure, but also in treatment of cardiovascular and renal disease. And they were introduced about 30 years ago, and again, seems like a long time ago, about the same time when Pink Floyd's released Dark Side of the Moon. And that was on the Billboard charts for 14 years, so it's pretty incredible. I guess rock never ages. I just read today in the Seattle Times that the Stones will give a concert in Rio, and they're expecting 1 million people to attend their concert. The most recent introduction in the area of cardiovascular disease and hypertension are these receptor blockers called ARB. And they were introduced merely 10 years ago. And this is the first class of blood pressure medication whose side effect profile is not different from a placebo. And that was in 1994. And that was the year that Gore invented internet. It turns out, although there are many hypertensive individuals in this country, blood pressure can be, at least to some degree, well controlled by changing our lifestyle, by increasing physical activity, by increasing ingestion of minerals such as potassium, magnesium, and calcium, weight reduction, and moderation of alcohol consumption. There's a lot that we can do for ourselves just merely by adhering to healthy lifestyle. Incidentally, this prescription for high blood pressure is very similar that American Cancer Society gives as well. So how have we done in terms of medical advances in the area of cardiovascular disease, or for that reason in medical field as a whole? So you can look at those parameters in many different ways. I chose to look at it as take a set of individuals and see how long they have lived. And those are the presidents of our country. And at least in part because of Roosevelt, we take much better care of our presidents. So if you have all the medical care that is available to you, one could live to, for example, 93, like Reagan, 30 years longer than FDR. Nixon died at age 81. So that was sort of interesting, because I thought for a president, that's young age. But I think the reason he died because Pat Nixon died a year earlier. And the statistics tell us that at that age, if your wife dies, you have 50% chance of dying the next 2 years. So for those of you husbands, you better take care of your wives if you want to live to a long age. I also like to mention that President Clinton, he probably will get to live to 90 because of all the advancements that have been made. And if he lived during the era of FDR, he would not probably live to age 60, which he will reach this year. So I took you through this very rapid journey through medical discoveries in the field of hypertension. And there are a number of lessons that I derive from that journey, that in order to make progress, we have to think out of the box. Building scientific bridges and communications are very important. I hope I cited some examples. Technological and computational developments are also very important. And needless to say, serendipity can also be very helpful, as was shown very nicely by Sir Fleming, who discovered penicillin. But when I look at all that, none of it would be possible without public support of research. Thank you very much.
Thank you very much for the previous introduction, and thank you, Dr. Bomsztyk, for that wonderful entry into this evening's discussion. I'm an interventional cardiologist, and an interventional cardiologist is someone who does minimally invasive, non-operative treatment of heart and vascular disease, largely using X-ray or ultrasound to help guide our procedures. So we avoid undergoing the knife and requiring anesthesia and all of the negative connotations of undergoing surgery, and many of our procedures are outpatient as opposed to a patient undergoing surgery. Now, the classic use of interventional cardiology is the treatment of coronary artery disease with balloon angioplasty procedure, and in this day and age, largely that is with associated stents, a metal scaffold. Coronary angioplasty is the terminology we use when we use any way to modify the artery, that is, you generally open up where it's clogged. So this was first performed in 1977. Andreas Grunzig, a East German physician who was working in Switzerland at the time, shortly thereafter moved to this country. He started using balloon catheters, which he would inflate in arteries. Now, he had to invent these balloon catheters, and he did that in his kitchen, and then would figure out how it could be used to open up the blood vessels. Now, balloon angioplasty worked surprisingly well to everybody's astonishment. However, there were some problems. There could be acute failure where the blood vessel would actually close immediately thereafter for several different reasons. And this occurred about 5% of the time. And when this occurred, because the blood vessel is supplying the heart muscle would start to die, and therefore such an individual would need to be rushed off to emergency open heart surgery to bypass that area of blockage. However, using these stents, the metal scaffolds, this problem has been largely resolved, and we don't see that as a problem anymore. A more common problem after balloon angioplasty was the development of restenosis, or re-narrowing of the vessel. I'll show you what I mean in a moment, which occurred approximately 40% of the time and was considered to be the Achilles heel of this particular treatment. Now, this also is improved with stents, as I will mention in a moment. Now, this is a coronary angiogram, which is performed by placing a tube inside the artery of the leg or possibly the arm and passing it up through the pipes that is the arterial system that allows us access to the arteries of the heart. Now, what you can see here is that this is the tube and this is the arterial system, and right here there is a narrowing, a significant narrowing. Now, if an individual has this type of narrowing, it would probably cause them some symptoms such as discomfort in the chest when they tried to walk, or possibly shortness of breath. Furthermore, this can actually cause such an inadequate blood supply to the heart muscle that actually some cells will die and cause what we now term as a heart attack. And if this area of blockage blocks 100%, somewhat abruptly, then this is the classic cause of a heart attack or a myocardial infarction. Well, in this day and age, we can treat that by bypassing it surgically by putting another blood vessel beyond it to this point so that we have bypassed this area, or more commonly, we will open this up with a balloon angioplasty procedure and often leave behind the metal scaffold as a stent. And let me just show you how we do that. Simply going through this tube, we pass a wire which we are able to manipulate through the X-ray, through the area of the blockage, down beyond that area. Over that, we have threaded then a catheter, a tube, that has a balloon on the end. And here you can see the markers of where the balloon is on one side and the other, so it's an elongated balloon. And over the balloon is crimped down the metal scaffold, or the stent. We'll then inflate the balloon. As you can see, the balloon inflated right here, with contrast in the balloon so we can see it under X-ray. And the stent, which is invisible to your eye here, is difficult for us to see even at the time. The stent is going to remain there after we deflate the balloon and remove it. And instead, what we see when we inject contrast is that that area where there was blockage, now we can see that there's a wide open vessel, and this will alleviate the individual symptoms quite well. Well, this is a coronary angioplasty, and this has been standard for the last decade or so. However, in the last couple of years, there's been a dramatic change in our ability to resolve this problem of restenosis. And this is a still frame of a coronary artery with a stent in it at this place, location right here. And you can see that there's a gap in terms of the vessel appearance because there has been scarring inside that stent and has caused recurring problems for the individual that suffered from this particular problem. Well, in the soil of Easter Island, shown here as a picture of an archaeology student who is digging in the soil, Easter Island, you may recall, is the place where they have the giant heads that nobody understands how they got there, and here's a close-up of those giant heads. Well, in the soil of Easter Island, someone discovered an antibiotic that had somewhat unusual properties, that it had anti-inflammatory properties. Now, if you're trying to kill off a bacteria with an antibiotic, you don't want anti-inflammatory properties. You want inflammation to resolve the infection. So this bombed as an antibiotic. However, they discovered that the properties that it had were very effective in reducing the scarring that occurred at the time of stenting. Now, because this particular archaeology student happens to be my wife, I learned something or two about Easter Island, which is one of the things I learned is that the native name for Easter Island is Rapa Nui. And because this is the name for the Easter Island, the antibiotic that is found in the soil of Rapa Nui is known as Rapamycin. And we've taken this compound and placed it on the stents using a very, very complicated way of doing it. And this has a strong anti-restenosis effect. Now, there is another compound that is found here in the Pacific Northwest from the Pacific Yew Tree. And this compound also, when applied to stents, will help prevent this problem of restenosis. So, these are the major advances in coronary angioplasty in the last 30 years or so, and I leave it to you to come up with your rock and roll song of choice for each of these different periods. 1977, it was invented. 1994 is when stents were released in this country, and in 2003 is when we started getting these drug-covered stents, or what we call drug-eluting stents, using either rapamycin or paclitaxel. And if we look at the incidence of restenosis, it has dropped precipitously over this period of time. So we are very excited by this major advance in coronary angioplasty. And now we're dealing with the problem of restenosis in only a few cases, somewhere between 5 to 10%. Well, now I want to switch directions completely and leave coronary artery disease and talk about something else. I want to talk about stroke prevention, because this is something that we are also doing as cardiologists. Now, many of you may recognize the people that I'm showing you right here, and they share something in common. Both of them have suffered strokes, and both of them, their strokes were felt to be caused to the same mechanism, that of a passageway from the right heart to the left heart, which allowed a clot that might have been circulating in the venous bloodstream to gain access by going from the right heart to the left heart, gain access to the arterial blood supply of the body, including of the brain. And when that blood clot gets to the brain, it can then occlude the brain and cause a stroke. This is Teddy Bruschi, the all-pro linebacker from the world champion at the time, New England Patriots. And this is Ariel Sharon, the unfortunately quite debilitated leader of Israel. And both of them had strokes felt to be due to this particular passageway known as a patent foramen ovale, or a PFO. Well, a patent foramen ovale is actually not an abnormality. The foramen ovale is a connection between the right atrium and the left atrium. And it was designed by the creative designer, whoever that might be, as a way of bypassing the lungs when we're all in the uterus. Because the lungs don't work when we're in the uterus. So it's more efficient for the heart to work if the blood bypasses the lungs, goes directly from the right heart to the left heart, and then can go to the rest of the body. So this is what the foramen ovale does. Now, when we're about 2 years of age, this foramen ovale fuses closed. Now, before then, it's functionally closed because of the fact that it is a flap of tissue, thin flap of tissue overlying a thicker flap of tissue, and I'll show you a picture of that in just a moment. With that thin flap of tissue, the pressure is higher in one chamber than the other, so that compresses that passageway, and it can only flop open every now and again depending upon pressure changes. As I said, at about 2 years of age, in most of us, that flap of tissue, or those flaps of tissue, will fuse together. But in about 10 to 20% of us, that does not fuse together, and we say it maintains its patency, and therefore we call it a PFO, a patent foramen ovale. Now, what we've discovered is that in young people, defined as less than 55 years of age, who have a stroke, about 40 to 50% will have one of these PFOs. So there's a statistical epidemiological relationship between stroke and this PFO. Now, furthermore, proof of concept has existed because a blood clot has rarely been observed to be crossing a PFO in a patient suffering from a stroke, as shown in this picture here. You can see this is an ultrasound, a transesophageal ultrasound picture, and it's labeled so we know exactly where we are. This is the right atrium, where blood returns from the body, and this is the left atrium, which is the collection chamber for the left ventricle, which pumps blood out to the body. And through this tissue between them, there is blood clot that is going through. And this is the foramen ovale right here, and this is the blood clot going through. So we have the smoking gun right here to know that this is what caused that particular individual's stroke. Now let me educate you a little bit more and show you exactly what we're seeing when we identify this Peyton foramen ovale. What we have here is a picture of an ultrasound of a heart where we can make out the right heart on this side and the left heart on this side. So this is the right atrium, and here you don't see very clearly is where the right ventricle is. This is the left atrium, and this is the left ventricle. This is the tissue between the right and left atrium called the atrial septum. We're then going to inject some bubbles just by taking a little saline and agitating it by shaking it up a little bit. We're going to inject that into a vein. The blood from the vein will then go into the right atrium. Well, the bubbles should stay in the right heart, where they're then filtered by the lungs. However, if there's a PFO, we'll see bubbles that cross from the right heart and into the left heart. And if we see any bubbles in the left heart, then we know that there is an abnormal connection or a PFO. And here, when we inject the bubbles are white, and you can see them quite clearly on the right side. But if you look carefully, you're going to see that there is some swirling of bubbles right there in the left heart. I'll take my pointer away so you can just watch it one more time, and you can see the bubbles there. In someone without a PFO, that won't be present. So a simple test like an echocardiogram can identify the passageway through this PFO. Well, here's a closer look at a PFO using a different modality, which is called an intracardiac echo, where we've taken an ultrasound probe from the vein in the groin, in the leg, and passed it up through the venous system to the right atrium, and actually doing an ultrasound from within the heart itself. So because of that, right here is where we're imaging from, and we're in the right atrium. So this is the right atrium, and this is the left atrium, and this is the atrial septum. Now, I told you that the atrial septum is comprised of a thick tissue and a thin tissue that are abutting up against each other, and that's what we're seeing here. This is the thick tissue, and this is the thin tissue, and between them you can see a potential passageway, and that is the foramen ovale, which is in fact open. Well, in individuals that have had a stroke that we feel is due to a clot which is traversed through the body and has not been filtered by the lungs but has escaped that filtering and gone through to the left heart, we can imagine the mechanisms that we might use to treat it. We can give anti-clotting medications, such as was given to Ariel Sharon, and of course led to a major bleeding complication. We can close the PFO surgically, and the surgeons are quite happy to do this. It does require open heart surgery, but it does only need then a couple of sutures when it comes to that. Of course, it is open heart surgery, and most people are inclined to try and avoid that. And lately, we've been using special devices that we can place in the cardiac catheterization laboratory as an outpatient procedure where we can close these by putting something that will clamp the tissue. When we do this procedure, we are very successful in that a recurrent event rate is quite low. That is, only about 1 to 3% of individuals will go on and have any neurologic event. And almost all of these are transient, something that only will last a few minutes and causes no permanent neurologic disability. And so this is quite encouraging because we appear to be avoiding any permanent disability by doing this outpatient procedure. Well, let me share with you an example, a real-life case of an individual. This is a 49-year-old male college basketball head coach who 1 year ago, almost to the day, developed severe fatigue, mild right-sided weakness, and spasticity of his hand, and he is right-handed. Now, he was a type A, denying kind of 49-year-old male, and he pretended that there was nothing wrong, despite the fact that he couldn't use his right side and it was spastic and he felt awful. He just stayed in bed for a few days and didn't tell anybody what was going on, and he was quite fortunate that he actually got better. However, 3 months later, during a basketball practice, he developed acute blurring of vision, dizziness, difficulty speaking, and again, right-handed weakness. His assistant coach, who happened to be his son, noticed that something was quite wrong, and he took him this time to the emergency room, where a CAT scan of his brain showed that he had actually had 2 previous strokes in addition to this one. So he had had multiple strokes. The echocardiogram, which actually I showed you a few moments ago, showed that he had a patent foramen ovale. He elected to have this closed using the techniques that we do in the cardiac catheterization laboratory, and I'm going to show you how we go about doing it. This is where the atrial septum looks like under X-ray. This is a catheter that has been placed in the vein in his leg, in his groin, and passed up into the right atrium, and through the hole in the heart, and into the left atrium. So we're going to inject some contrast into the left atrium. And what we're seeing here is the contrast, which is shooting across a little bit, is shooting across at this atrial septum right here, and you can see this contrast that is shooting across right there. And I simply did this to orient you that this is the level of the atrial septum for the next pictures that I'm going to be showing. Well, then we put our intracardiac echo probe up here, and it's simply this little thing right there that is coming up from the vein in the groin. And now we've got a wire that is across the PFO and a balloon that is over the wire. And we simply inflate the balloon to get an idea of how big the PFO is when we stretch it open, because now we can see exactly where it is. There's a waist in the balloon right there, and we know precisely where it is. And I'm just showing you this so that you are, again, oriented in terms of the area that we're going to be seeing. Keep in mind that much of what we're doing is actually invisible under X-ray. We can only look for certain landmarks, and this is an easy one for us to look at. Before I go to this, let me show you actually how the device works. And so I'm going to come over here. I have some of these devices, and I'm going to show it to you. So the device we used in him, it looks like a double umbrella. If we could see it right here, and this is a used one, so it's not quite so flat, but that was by design so you could see it. It's a double umbrella that one umbrella goes on one side of the tissue and the other umbrella goes on the other side of the tissue. And so that's basically what it looks like after it's in place. And here I've shown you how we have it loaded into our system, and so we have it folded inside a plastic tube. And here you can see the 2 umbrellas. We have one right here. We have a little bit of a post in between, and then the second umbrella right there. When we find it that we have it in the right place, we simply push the umbrella out of the tube. We're, of course, in the heart when we're doing this, and we're pushing it out. We push it this side out on the left atrial side. It pops open. We then pull it back until we're up against the tissue of the atrial septum. And then we push out the other side, and it's open. And here I'm going to pull this to see that they're separated there. And simply, after we've looked and made sure that everything looks okay, we then will take our back end of the device here, and we just push a little button, and this thing is going to just pop off and go flying. That's about how long it takes for us to do this procedure. It's a very quick procedure in the cath lab. And now let me show you how it looks under X-ray. So here we are. We have our tube that is coming up from the vein in the groin that is across the PFO. Remember that this is the level of the PFO. And we have that device that is sitting inside the tube. So if we just play it. So here we are now pulling it up against the atrial septum, and there we're releasing the right atrial limb right there, very quick. We still have a hold of the device, so we can remove it, take a look and make sure it's a good result, and if we don't like it, we can pull it out. Oh, and here we are making sure that the device is not going to go anywhere. We're pushing and we're pulling and making sure it's in there nice and snug, and then we simply let go of the device as I showed you, and it doesn't fall on the table because it's snug up against the septum. And then we can pull everything out, and the patient can leave the hospital 3 hours later. And here is what the device looks like if you look at it under X-ray. It's kind of entertaining. It looks a little like a couple of spiders that are bouncing around in there, so I had to show it for entertainment value, if nothing else. Of course, we're monitoring the whole thing under ultrasound, and this is the intracardiac ultrasound of the procedure. Now we've got our ultrasound is right here in the right atrium, so this is the left atrium. Here you can see the device, I think, quite nicely. It looks exactly like that, the thing that I was showing you, the double umbrella that's capturing the septum. And here we're injecting bubbles into the right atrium to make sure that none are going across into the left atrium to make sure that we've got a good result. So that's how we do the procedure. Now, Ariel Sharon was supposed to have this procedure done, and unfortunately his doctors decided to put him on blood thinners while they were waiting to do the procedure, and he had a bleed inside of his brain. This, I think, highlights the downside of the alternative treatment is the potential for this type of thing to occur. On the other hand, Teddy Bruschi had one of these devices placed and, of course, went back to play football this year. And if I'm not mistaken, actually got Comeback Player of the Year award or shared it with somebody. I might be mistaken about that. But he had continued on with his successful career. And the patient that I mentioned that I presented to you is shown right here. The coach of the Montana State University basketball team with his son right next to him. He tells me that not only has he not had any further strokes, but he actually has had increased energy when he went on his annual hunting trip this summer, where he was actually leading the group rather than lagging behind as he had in years past. I don't know whether or not I should take any credit for that, for having fixed his PFO. However, I have insisted upon taking credit for the fact that his basketball team this year is having the best record of any team that he's ever had while coaching over the last 30 years. And I'm quite certain it's because of the procedure I did for him there. Well, what's interesting is that in doing this, we may have actually stumbled upon a new treatment for migraine headaches. Whoa, where did that one come from? And what we discovered is that of patients who presented to have their PFOs closed due to stroke, about 50% of them will have a history of migraines. About 15% of the overall population has a history of migraines. Out of curiosity, does anybody in here suffer from migraine headaches? Okay, about 15%. Now, of patients who I see in my practice to close their PFOs, about 50% of them will have migraines. So there's some sort of a funny statistical relationship. Furthermore, to our surprise, nobody expected this, but when we started closing these PFOs, patients started coming back to us and saying, hey, you know, I used to have migraines, and they're gone. So when we started checking up, we found out that about 50% of the patients whose PFOs we closed because of strokes, about 50% of them, their migraines went away. And about 70% of them, their migraines got better. Why is this? We're not really sure. I attribute it to those 4 humors of Galen having something to do with it, but we really don't know. So now we're starting to look at people who haven't had strokes, but just have migraines. And we found that of the non-stroke migraine population, about 50 to 60% will have a PFO, whereas only 10 to 20% of the normal population. So this is quite interesting. Well, now I want to share with you another example. of a patient that we treated recently. A 44-year-old male with severe migraines nearly daily. Now, his job is he's an executive in the aeronautical industry, and unfortunately, one of the triggers for his migraines is flying, which is a problem because his job was to fly and show people how to use their equipment. And he had to fly all over the world to do this, and so this was causing him a great deal of distress. And after one trans-Pacific flight, he actually had a very profound neurologic event, including transient global amnesia. He was actually admitted to the hospital with a series of neurologic symptoms and then had no memory of it. And because of this, he was grounded from flying even for vacation. So he couldn't work, he couldn't play, he wasn't very happy. He went to our migraine specialist, and he had been to several, and all medical options were exhausted in treating his migraines, and he had significant side effects from the medications, such as problems controlling hypertension. So in this case, there was no other therapy to offer him, according to the migraine specialists. So as an only option available, his PFO was closed 2 months ago. Now, I won't show you the pictures because they're virtually identical to the previous case, but I can tell you, having seen him today in clinic, that his migraines have now resolved completely. And in fact, he told me, he said, you know, I'm doing all kinds of crazy things. I'm eating chocolate, you know. I'm drinking red wine, you know. I'm sleeping late. He's gone back to work. He is off of all of his anti-migraine medications. He's having no side effects, of course, because he's taken them off. He's, as I said, he's gone back to work. He's gone on 2 vacations with his wife, where he has flown, and is looking forward to even others. So in this case, it's a very, very dramatic result. However, I'm not sure that this isn't a placebo effect. After all, he was well prepared for this to have a dramatic effect, and it has. Careful studies clearly need to be done to make sure that we aren't doing something that is simply a placebo effect, and these are being performed and are designed. The first study is actually a British study. It's a rather interesting study because there is a sham procedure. All of the patients who are in this study undergo general anesthesia so that they don't know what's going on. They have a transesophageal echo, so the echo probe is put down their throat, and a catheter is placed in their femoral vein. Half of them get their PFOs closed. The other half get nothing more than this particular procedure. Of 500 patients that they wanted in the study, they had 10,000 people apply to be in this study the first week that they put it on a website. So this is obviously an area of much interest. Well, future treatment options include the potential to close these PFOs without leaving any device behind, or a deviceless closure. And a company here in Seattle and a company in California are working on these to effectively weld this tissue together using a device such as this. And this is something that we're eagerly anticipating and will be involved in the research here at the University of Washington when this has been approved by the FDA for study later this year. Well, thank you very much for your attention, and it's been a pleasure to speak with you today.